afternoon. Thanks for joining us today for our webinar. My name is Carmen Boone, and I'm Education Coordinator from Oregon Pacific Area Health Education Center. We're a hosted agency of Samaritan Lebanon Community Hospital. And our agency mission is to promote access to quality health care through community and educational partnerships. Today, I'll be your host and moderator, and we have Dr. Amy Weiser joining us today to share her knowledge with our presentation, You Are the Key to HPV Cancer Prevention. So some housekeeping items first. You'll see that all microphones are muted. They are in listen-only mode. They'll remain muted during this session. Please use the question on the menu and type your questions and comments at any time. We will be monitoring them throughout the presentation. The slides and handouts can be downloaded on the handouts menu. If you have trouble downloading them, just send us an email and we'll help you as soon as we can. Again, our webinar is being recorded and will be available on our YouTube channel. And if you have questions, feel free and send me an email. To obtain your certificate, your credits, you must log into www.eeds.com and enter this activity code for today. Please write it down for your records and keep in mind that it lasts only 1 week. We will be emailing you all these instructions and links today, a couple of hours after this webinar. This presentation is jointly provided by Samaritan Health Services, American Cancer Society, and Oregon Pacific Area Health Education Center. And the presenters and the planners of this activity report that we have no conflicts of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. And today we have Dr. Amy Weiser. She's a family physician and she loves promoting health and wellness, and from these, the positive effects she sees in her patients. Her clinical interests include gynecological health, maternity care, and gender-affirming healthcare. Now, without further ado, I leave you with Dr. Weiser. I'm gonna turn the presentation to her.
Okay. Hi, everybody. Thanks for joining. You can tell that haircut in that picture was pre-COVID. So many things have changed in the past year and a half. Perfect. Okay. Well, I hope that's the hardest thing that we encounter during this hour, but you never know. I am working from home. My dog is playing with the neighbor kids next door. So we are just, as we are. But I'm delighted to be invited to talk to you about HPV cancer prevention and talking about the HPV vaccine. So as Carmen mentioned, I am a family doctor. I live up in Portland. I work for OHSU in the Department of Family Medicine. I get to do a lot of cool things. One of my favorite things is talking about HPV and trying to prevent really all the sequelae that HPV can cause in genital warts and especially cervical cancer. So again, as Carmen said, this talk is sponsored by the National AHEC organization as well as Oregon Pacific AHEC, who kindly invite me to share with them these educational programs. I have no financial disclosures or anything that I need to share with you. And so as we go through, we're going to talk about why HPV vaccination is important, right? Why are we spending all this time? What does it do? How does it do it? We're going to talk about how to appropriately vaccinate our patients for HPV. What is the schedule? We're going to talk about how best to talk about HPV vaccination and deliver some self-efficacy in having these conversations. We want to make sure that we can reassuringly, confidently give good responses to parents and to patients when they have questions about HPV. So let's talk about the infection itself as well as the disease. This first slide is a little busy, but HPV is complicated. So we'll kind of talk through it together. So HPV, the human papillomaviruses, are a very common family of viruses that affect epithelial tissue. And as the slide depicts, HPV types differ in their tendency to infect cutaneous versus mucosal genital epithelium. More than 150 HPV types have been identified, including over 40 that infect the genital areas. Genital HPV types are categorized then into high risk and low risk. The high risk types notably include HPV 16 and 18, and these can cause cervical cell abnormalities. They are precursors to cancer, as well as, well, responsible for development of cancers. In addition to cervical cancer, HPV infection is the cause of some cancers of the vulva, the vagina, the penis, and the anus, as well as cancer of the oropharynx, which we're seeing more and more of over the years. Low risk, kind of in the middle of this diagram here, including types HPV 6 and 11, cause benign or low-grade cervical cell changes and genital warts. So this is more like active infection, is what you would see. So this infection, how common is it? Well, most of us, as most females and males, I would say every human being, will be infected at least with at least one type at some point in their lives. So about 80 million Americans are currently infected. Each year, about 14 million new cases or infections occur, and it's very common for people in their teens and early 20s to have this infection because it usually occurs soon after sexual debut. The kind of the crazy thing is that most people will never know that they actually have been infected unless it sticks around long enough and genital warts occur, or if they have a cervix, they get cervical cancer screening and abnormalities pop up. But it really is ubiquitous to an extent. So the number of cases associated and attributable to HPV is represented in this slide. It shows the number of HPV-associated cancer cases that were diagnosed and reported each year in the United States. Oops, uh-oh. What did I hit? Ah, nope, points off for me today. Sorry about that, you guys. Let's see. Nope. Okay. Alrighty. Oh shoot. Ah, no, don't leave the webinar. Oh my goodness. What is happening here? I wanted to move my little pop-up screen here so you could see things. Alrighty, well, we're just gonna deal with it. Okay, so back to the slide. The slide shows the number of HPV-associated cancer cases that were diagnosed and reported each year in the US from time period between 2012 and 2016. And it's sorted by sex, by cancer type, and HPV type. So it also includes associated and attributable. So cancer registries do not routinely collect data on whether HPV is in the cancer tissue. We estimate the number of HPV-associated cancers. Researchers look at cancer in parts of the body and cancer cell types that are likely to be caused by HPV, and these include all carcinomas of the cervix and squamous cell carcinomas of the vagina, the vulva, the penis, the anus, and the oropharynx, including the base of the tongue as well as the tonsils. And in this analysis, all cancers were microscopically confirmed. So a CDC study published in 2016 used this population-based data to genotype HPV types from cancer tissue. The data was then used to estimate the percentage of these cancers that are probably caused by HPV, which is what we call HPV attributable cancers. Because when I looked at this, I was like, what are they talking about here? And how can we attribute it? And that is the science behind it. So the graph shows the total number of HPV-associated cancers and uses the attributable fractions from the genotyping study to estimate the number probably caused by HPV types. And the types were grouped as 16, 18, which is the dark blue bar, and then other high-risk types, which included 31, 33, 45, 52, and 58, and that's more of that teal color, and then other types were that white area of the bar. So looking at this in another way, we can show that All sexes, all races, all ethnicities are affected by HPV. The hashed lines for each of the sets of bar graphs represent men, and then the non-hashed ones, the shaded in ones, include women. So the incidence rate, what we're talking about, means how many people out of a given number get the disease each year. And the incident rates of HPV-associated cancers do vary by sex and race and ethnic group. In each race and ethnic group, though, women had higher rates than men. And among women, Blacks and whites had higher rates, and Asian or Pacific Islanders had lower rates. Among men, whites had the highest rates, and Asian Pacific Islanders had the lowest rates. Non-Hispanics had higher rates than Hispanics. So this just goes to show that HPV, like COVID, does not care about your background or your sexual orientation or your gender identity. It is there, and it affects everyone fairly equally. So cervical cancer is the most common HPV-associated cancer among women. This is the one that we really think about. It's also the one that's most preventable of all the female cancers. So this shows that worldwide, HPV-associated cervical cancer still is causing over 300,000 deaths a year, as well as close to 600,000 new cases. And even in the United States, where we have good screening programs, back a couple of years, this needs to be updated with new data once we get it, but it was causing about 13,000 new cases a year and 4,000 deaths in the US. So simply put, we can do better. The sad part is that a lot of these cervical cancers are occurring in women less than 50 years of age, and a quarter of the cancers occur in younger women, ages 25 to 39. A cervical cancer diagnosis and treatment is devastating to patients, their families, for a variety of reasons. Negative effects on their health, of course, their welfare, finances, ability to work. And so, as well as the treatment for cervical cancer, which at a minimum is removal of the cervix, but may also include radical hysterectomy, radiation, and or chemotherapy. This brings us to the next slide, which talks about cervical precancer in the United States. So anyone with a cervix. Not only are we seeing cervical cancer in this country, but we see a lot of high-grade cervical lesions every day, about 200,000 every year. And this is what's key, right? This is pre-cancer. This is before it turns into cancer. About 1.4 million patients will be diagnosed with low-grade cervical dysplasia or abnormal changes of the cervix. And then each of these patients are faced with this emotionally packed news of an abnormal pap and needing therapy with a colposcopy, and then we'll wait to hear those results, and then, you know, have determined whether or not they need forward therapy. And in this case, it's diagrammed a cold knife cone therapy, which we do sometimes, but we also do a lot of LEAP therapies. But suffice to say that though this is also traumatizing, it is a lot better to be able to identify and treat pre-cervical cancer rather than frank cervical cancer. And so, as we know that HPV is responsible for any of these changes, it's also great if we could prevent the infection of HPV before it causes any of these changes. And that brings us to the next section of the talk, which is when we talk about the HPV vaccine. So what is this vaccine? It's a recombinant L1 capsid protein that forms these virus-like particles or VLPs. In and of itself, it's non-infectious, it's non-oncogenic, it's not going to cause cancer. It's a vaccine. We kind of wanted to do the opposite. And it produces these higher levels of neutralizing antibodies than a natural infection of HPV can induce. The HPV vaccine has evolved over the years. Initially, it only included 16 and 18 for the high-risk types. And then quadrivalent was around for a while, which many of us were probably not exposed to, that would be horrible to say that, but are used to having in the clinic within the last decade or so, which covered 6, 11, 16, and 18. And now we've transitioned to the 9-valent, which cover the 4 original types from prior vaccines, as well as 31, 33, 45, 52, and 58, where these high-risk subtypes of HPV are also responsible for many cervical cancers. So we're expanding the coverage as we learn more and more about HPV, the epidemiology of it, how scientifically it works, what it does in the cells. And so we're able to have a really robust vaccine that we are giving to our community members. The vaccine is recommended to start at age 9, but most of us in our clinics, because we also give other vaccines around age 11 or 12, we'll end up giving the HPV vaccine around that age. So we say that, you know, around age 11 or 12, that's an on-time vaccination. And those individuals will get 2 doses of the vaccine. It's a 2-dose series. So it'll be 2-dose even up to age less than 15. Once you hit age 15, you will need a 3-dose series. So it's nice to start it on time, ages 11 and 12 for your patient population. They only need 2 doses versus 3. And again, this is more of the spelled out dose recommendation. So if you start the vaccine series on or after the 15th birthday, again, it's 3 doses. So you give the first dose on day 1, the second dose should be 1 to 2 months after the first dose, and then the 3rd dose should be administered 6 months after the first dose. It's great because it's kind of a short interval period. You're not thinking about years to come back and finish off that series. You can do it within a 6-month period of time. Likewise, if you start the vaccine before age 15, it's a 2-dose series, and that second dose is usually given around 6 months after the first one. So you can really do a short interval series and have improved completion of the series itself. One question that comes up is, how safe is this vaccine? So we're going to move to chat about that next. And what we can say is that there are many organizations that work with the CDC, the FDA, other academic healthcare centers, other partner organizations that really spend a lot of time studying vaccine safety as well as efficacy. I think that the major one that we think about would be the VAERS system, the Vaccine Adverse Event Reporting System. And this is actually a system that it's self-triggered. So a provider would report this, or an institution would report if there's any negative effects or side effects from the vaccine. The great thing is that it's probably over-reporting in a way, because even minimal adverse effects can be reported. But it also worked well because any of the larger, more systemic issues that are found are really given a great forum to be studied. And the VAERS system has actually been studying this vaccine for over 12 years. So what do we know? We know that the vaccine is safe from these studies. The safety studies have been very reassuring. HPV vaccine in and of itself has a very good safety profile. We know that the CDC and the FDA continue to monitor and evaluate the safety of HPV vaccines, along with all vaccines. And this gives us a way as clinicians or providers to reassure patients and parents who may have concerns that the HPV vaccination is not truly safe. We have data that supports that it is. We also want to think about, well, why are we doing this? Why are we giving this vaccine, and what can we see it doing? Do we know that it is indeed helping to prevent cervical cancer? And we can look at this in several ways. So we know that early on, studies have shown that within months to years, we see decline in the incidence of genital warts. We see a decline in the prevalence of vaccine type. And then we go on to see a decrease in cervical precancer incidence. And these studies have been done in this country. They've been done in other countries as well. Australia has some beautiful data that really demonstrates this from early on, because they were one of the first countries who actually had HPV vaccine as a requirement. But we can talk about it in this way. So this is from the NHANES study. It's from the United States. So the NHANES is the National Health and Nutrition Examination Survey, and it's a program of studies designed to assess the health and the nutritional status of adults and kids in the US. This graph demonstrates vaccine type prevalence by era. And we're talking about pre-vaccine era, so 2003 to 2006 is represented in gray. And then the early vaccine era, so 2007, 2010, which is, came out in 2006. So really in those first few years after HPV made it to the domestic market, are represented in blue. And what we can show on this are 4 different age groups, as well as prevalence, and that there is a 56% decrease in vaccine type HPV prevalence among the youngest age group in the early vaccine era, compared to what was the pre-vaccine era and represented in gray. No changes were detected among the older groups, but this makes sense because the older groups were not receiving the vaccine to the extent that the younger population was. So we know that the prevalence of HPV, so 16, 18, 6, and 11 were going down within just a few months to years after we started the HPV vaccine in this country. We know that later vaccine era continued to show a decrease in the prevalence of the vaccine type. So now we're going a little bit further on. We're including a later vaccine era, which are the years 2013 to 2016. And we see again that we have decrease in that early population 14 and 19, an 86% decrease versus a 56% decrease in prevalence. But now, as our population is aging, we are also seeing it in older age groups. So the 20 to 24, very impressive with a 71% decrease. We know it's working. 25 to 29 as well. Again, the older, the 30 to 34 in this particular study, we're not seeing a whole lot of decrease. And why? Because these people were not ones who got this vaccine years ago. They were in that older cohort. What we also know is that from this, the pre-cancer incident rates are also going down. So you can see the 2 graphs that start in 2018 are followed until 2016. The 18 to 20-year-olds as well as the 21 to 24-year-olds are having decreased incident rates per the HPV Impact Project of pre-cancer, which is lovely. So again, genital wart prevalence is going down, vaccine type prevalence is going down for HPV subgroups, and then the pre-cancer rates are going down. So we can see the impact that this vaccine is having on our communities. We know that it's safe, and we know that it's been well studied and is continuing to be well studied. One question that comes up then is, okay, and especially now since we're talking about COVID and are we going to need a booster, is, well, how long does this HPV vaccine last? If you give it to, someone who's less than 15, do they need a booster? And there's no evidence of waning protection. So a lot of the studies have been 10 plus years, and there's been no evidence that says that there's any waning of that immunicity toward HPV. And we continue to study this as we go along. So for right now, no booster is needed. So again, vaccine works. We have population impact studies against these early and mid outcomes. It's been reported in our country and multiple others. We know that the vaccine lasts, no evidence of waning protection, and we know that it's safe. So we have all this great information, and now it's a matter of how do we communicate this to our patients who may not have this background, who may not have gone to this talk, and may not have had the clinical education that we have, right? And I think about it this way, that if I wasn't in medicine, when my child was at the age to receive this vaccine, the HPV vaccine, I wouldn't have been aware that it exists, because when I was a kid, or even when I was in my early 20s, it wasn't a thing. So I really come at a conversation from that perspective that, a lot of people may not even know that this is something that exists, that we should be talking about what HPV is. So framing the conversation so it's educational, it's engaging, is very helpful. We know that coverage of the vaccination for HPV is not as great as it could be. So this is a graph from 2006 to 2018 for the US talking about our adolescent vaccines. The blue and the red at the top represent the population having at least one Tdap vaccine and meningococcal vaccine. And then we go to the ones toward the bottom, right? So the yellow and the green and the orange. So the orange represents a population having at least one HPV dose. You can see that there's a fairly statistical significance, significantly difference between the prior two vaccines and the first dose of HPV. But then as we've fallen along, well, that yellow and that green for having completion of the series continues to go down on the graph, despite having better campaigning and better education about HPV over that span of time. So we can do better. And talking about this, you know, as people come into your office, how can we do better? Well, we know that for right now, if we took advantage of every time someone in this age range came in, we could have a 94% vaccination rate for all adolescents. But in actuality, we only have around 64%. And then if you take a look for binary boys and girls, we also have about that actualized percentage as well. So we are missing some windows, and one of the ideas is how can we close these windows so that we don't miss these opportunities going forward. Let's see. One of them is to receive a firm recommendation from your provider. So this study was from NIST back in 2018. And it basically said, you know, did your provider recommend the HPV vaccine? And it's either yes or no. And for those who said yes, which was a majority, of those, about 75% did have the vaccination. For those patients and families who did not receive a recommendation, the vaccination rate dropped to about 47%. So what we engage, how we talk about this vaccine and a person's health has a great influence on vaccination rate uptake. So there were other studies trying to explore this more. So parents of unvaccinated adolescents, they asked, why are you not giving your kid this vaccination? Why did you not pursue this? And a variety of explanations came up. My child is not sexually active. I'm concerned about the safety or the side effects. I don't feel like it's needed. I'm not aware of it. But what continuously popped up in a lot of these studies is the fact that providers didn't recommend this vaccine. And that is something that we have influence over, right? This is a variable that we can change by how we present the vaccine and how we go through our day-to-day in our clinical setting. Other studies said, well, let's look at the value that parents place in the vaccine. So is there this, the suspected theory was that HPV vaccine would not be as high in priority compared to other vaccines for the parents that were interviewed. So we thought, well, maybe, you know, Tdap would be high, the flu vaccine would be high, but HPV would not be as significant, and that theory was wrong. It is really just, you know, aligned with all the other vaccines that adolescents receive. What was interesting is that the second arm of the study really interrogated clinicians and asked them what they thought parents placed on HPV vaccine. How important did clinicians think that parents held this vaccine? And this is where this disconnect occurred, because clinicians thought, well, they don't feel so strongly about the influenza virus, but they really don't feel as strongly about the HPV virus. And that is wrong. So we had our own transferences guide our opinions when the data shows us otherwise. So the perceived and real concerns of parents influence how clinicians recommend the HPV vaccine, we have learned. And one of the ways that we need to do this, which I've been harping on already, is that HPV vaccination coverage is higher among a patient whose parents reported receiving a recommendation. So an effective recommendation from you is the main reason that parents may decide to vaccinate. Many parents in focus groups stated that they trust their child's clinician and will get the vaccine for their kid as long as they receive the recommendation from the clinician. So we have a huge responsibility. So how do we effectively recommend an HPV vaccination? Well, what we want to do is do it the same way every single time we do it. So the same way, same day. What does this mean? It means that we're recommending the HPV vaccination the same way that we recommend the tetanus booster, the Tdap, as well as the meningococcal vaccines. And we say, let's do it today. So we're going to recommend that it happens the same day that you have them get the Tdap and the meningococcal vaccines. Meaning that we can say, your preteen needs 3 vaccines today to protect against meningitis, HPV cancers, and pertussis. We want to make sure that HPV cancers is not said last because it's not an afterthought. This is just as important as protecting against meningitis and pertussis. And we're bundling these recommendations, right? We're going to say that they come all together. How can we do this? And we can go through some examples. We can say, well, now that Sophia's 11, she's due for 3 vaccines, and these will help protect her from the infections that can cause meningitis, HPV cancers, and pertussis. So we'll give you those shots today. Some of us may think, geez, this is kind of brief. I mean, I don't know how well we know Sophia and her parent, but perhaps they would like more information from this. And we have handouts, of course, that come with the vaccines that share more information, but they can be a little lengthy. So we can kind of hedge our bets in the middle here. We can say that the first vaccine that we're going to give you today, Sophia, is to help prevent an infection that can cause meningitis, which meningitis is rare, but it can be deadly. So we want to protect you. The second one is to prevent a very common infection, HPV, that can cause several kinds of cancer. So it's a cancer-preventing vaccination. And the third is the tetanus booster, which also protects against pertussis so that you don't get whooping cough, and more importantly, so that you don't spread whooping cough in the community. So we'll give you these shots at the end of our visit today. What questions do you have for me? And so modeling it this way, and of course, we all have our own flavors and personality, but this is a way that we can have some buy-in, some education, some engagement, and also an opportunity for questions if parents or Sophia would have any. And some parents need reassurance. Many parents will simply say, okay, these 3 are being recommended, let's do it. Some parents may be interested in vaccinating, but still have questions. And I think that interpreting a question is, they need additional reassurance from you, right? They're not arguing with you. They just need more information and they need reassurance. And be sure to address what their real concern is. What is their main concern with this? Try to get to where the worry lies, as this will have most benefit for your conversation as well as for the immunization status of the child. Other questions that come up, why does my child need HPV vaccines? And the question may also sound like, well, my kid doesn't really need that vaccine, does she? So regardless of how parents ask that question, we want them to know that HPV vaccine is very important for cancer prevention. And so you may say that it is important because it prevents cancer, and that's why I'm recommending that your child start the vaccine series today. What cancers are caused by HPV infection? Well, do they want a list? Maybe, maybe not. You are able, from the brief slides in the beginning of this talk, now able to share all of this. But really the research from the CDC shows that parents aren't aware of all the cancers that can be caused by persistent HPV infection. So some parents may ask you about the cancers that are caused by HPV infection, and I would say to share as much as you feel comfortable with based on the health and medical literacy of the family that you're talking about. So you could say, persistent HPV infection can cause cancer of the cervix, the vagina, the vulva. A lot of people don't know about the vagina and the vulva. Cancer of the penis in males, and cancers of the anus and the throat in both. So really, after you get past cervix, a lot of eyeballs will open a bit wider because people don't realize this. And we want to help prevent infection with the HPV types that cause these cancers by starting the HPV vaccine series today. Is my child really at risk for HPV? And I think that this is a reasonable question for a parent to ask. It's hard for a lot of parents to see their 11 or 12-year-old as being at risk for HPV infections, and they may ask about this. So you can say it's a very common virus that infects both males and females, so everybody. We can protect your child from the cancers and the diseases caused by the virus by starting HPV vaccination today. Kind of along that theme, a question is, but why are we doing it at age 11 or 12 years old? Because some parents may think that, geez, this is really young. My kid is not sexually active yet. You know, we're not into any sexual attraction. Are we really, like, is this way too early? And is this, for whatever reason, going to open the floodgates and get your child interested in sexual activity? And I think about it this way, that before exposure is when we want the vaccination to occur. We don't want to wait for the exposure to occur, right? So this is, we recommend kids to wear the bike helmets when they go out for a bike ride or a skate ride or a scooter ride. When don't we want them to put it on? Well, after they've already come back from riding their bike. We want them to put it on before they do anything outside and could fall, because that's how protection works. So this is very much akin to that. And as I said, you know, some patients may, or some parents of patients may say, gosh, does this mean that they're going to have sex? And my goodness, I hope that they're not spelling it by letters and can actually say that word. But this is a great time to actually start sharing information about development as a child turns into a teenager, and can really open the door for a lot of great conversations, if not with the parent, then with the provider as well. Making sure a child is taking charge of their health as much as they can for their appropriate age, but enabling them to be their own healthcare advocate. However, you can share this. Studies tell us that getting the HPV vaccine doesn't make kids more likely to have sex. I made sure my child or grandchild or whoever got the HPV vaccine, I recommend we give it to your child today as well. And, you know, a lot of people are not comfortable sharing this. I am. I tell people that my child got their shot, that they did well with it, that they didn't have any side effects from it, that they were very pleased to get it because then their mother could stop yammering at them about the HPV vaccine. And the child also says that I say the word vagina too much, but you know, we have these things. That's education there, folks. But really to be able to share. And if you don't want to share personal stories, that of course is fine, but you can quote the American Academy of Pediatrics, the American Academy of Family Physicians, the American College of OBGYNs, the CDC. So there are a lot of resources that people may recognize, and that you can use that to just kind of enforce your where your stance is. Next question is how long can we wait and still just give 2 doses? So some parents like to think that they can wait another year or 3 because nobody likes getting immunizations, but you know, the 2-dose schedule is recommended before their 15th birthday. And I don't recommend waiting because older teens have busier schedules, because more difficult to schedule an appointment. And we don't want to wait until age 15 because then they get 3 shots. So usually if you're talking to the kid before, you're like, if you do it today, you get 2, versus you wait and you get 3. They're like, 2, please. So it's best to start the series as early as possible. Concerned about the safety of the vaccine. A lot of people read things online. That is not research, that is online. Do you really know if it's safe? And we can say, indeed, we know that it is safe because of the studies that have been going on for the last like 12 plus years and that continue to go on. And then can HPV vaccine cause future fertility problems? It seems to be a trend in discussing any immunization lately. And I'm not quite sure where this is coming from. But there is no evidence available to suggest that getting HPV vaccine will affect future fertility. Women, or those with the cervix, who do develop HPV precancer cancer and require treatment, those are the people that could have limitation in their ability to have children due to complications, of course, that could include a hysterectomy if indeed you do develop cervical cancer. So kind of flipping it and sharing it that way is a reasonable tactic as well. Other things that parents may present to you, well, we only want the vaccines needed for school, right? Why am I going to get my kid the HPV vaccination series if it's not required? Well, school entry requirements don't always reflect the current recommendations to keep your child healthy. So HPV vaccines, along with other vaccines, will protect your child with the best protection. So it's important to explain the difference between a recommendation that you're making for the health of your child versus a legislative decision. A side note, about 21 states are starting to require HPV vaccination for their population of middle school, high school students, 21 states and the District of Columbia. There are some states like Rhode Island that have requirements that if you don't have this, you have to have a religious reason why, or some sort of a medical contraindication, which there really isn't any. So that is hopefully in the future for America in general. Oregon is not a state that is listed in those 21s as of yet, but I would imagine that this would be similar to the kids that come in before starting 6th or 7th grade, which say, I need my immunizations up to date before they will let me through the door. Kind of a safety catch there. That is my guess for the future, my hope for the future. Would you give the vaccine to your kids? We kind of already chatted about that. And you can answer it as appropriately to what feels good to you. Good questions. When do we need to come back? So when do we need to finish the series? And there is a need for parents to be told. Most parents don't know how many shots are in the series or what the timing is. Remember, they never, had this when they were a kid, so they don't know. We could say since your child's younger than 15, they need to come back for a second shot in 6 months. When you check out of the office, make an appointment for that second shot. Put that appointment on your calendar, in your phone before you leave today, because we want to increase the compliance and the continuation of the series in totality. And then since your child is already 15, they'll need a second shot in 1 to 2 months. And really, this just depends on your office kind of flow and protocol. Anywhere between 1 and 2 months is fine. And then they'll need the third dose 6 months from today. And again, make those appointments before you leave. Put it on the calendar. Put it on the kid's calendar. Kid has an iPhone. So make sure that everyone's on the same page. And again, it increases your completion of the vaccine series. As a parent, I can definitely say that this is helpful. So if a parent has questions after your recommendations, well, you want to listen to them and respond. Some parents simply want to talk about it a little bit more and get your thoughts and your answers on it. And your willingness to listen to the parents' concerns and really engage is going to behoove everyone in this situation, as it can help to build trust in you as well as the recommendations. And if you encounter a question that you don't know the answer to, just acknowledge that and share what you do know, and you can always circle back to them after finding the answer to the question that they've posed. So what if you do all that and a parent says, no, thank you? Well, saying no, thank you or declining the vaccine series isn't final. The conversation can be revisited. I have patients who every year do not win the flu shot, and they know that the next year I'm going to ask them in the same way, and we were going to have another conversation about it. It's not final. In the conversation with at least one action you both agree on. So if it's a matter of feeling more comfortable, you could give the patient something to read or the parent something to read, or at least saying, well, next time we see you in the clinic, we'll continue discussion of this. The last thing in this declination form, I've never been in a clinic where we suggest a vaccination and the patient and the parent don't want to sign a form. This may just be a practice or an institution-based protocol, but I've never seen this. So take it as you will. One thing to think about before we end is that the recommendation of the vaccine is between the ages of 9 and 26 for both males and females. And recently, there has been extension of the vaccination age to 45. The FDA, the ACIP, the ACCP have all said this is a great idea. The tricky bit, though, is how do we recommend this and who do we recommend this to? So, as we said in the beginning, most patients, most adults, human beings, have already been exposed to HPV at some point in their lives. though not necessarily to the HPV types that are targeted by the vaccination, because there's over 150 types and over 40 types of high risk. But at any age, new sexual partner is a risk factor for getting a new infection. People who are already in a long-term, mutually monogamous, mutually is the keyword there, relationship are not likely to get a new HPV vaccine. The HPV vaccine prevents new infections, but doesn't treat existing infections or diseases. And this gets a little gray area, because by the time an HPV infection is identified, just the way that the virus works, this infection has been there for maybe a decade or so. So it's not like you have a new partner and then it's going to show up tomorrow. It doesn't usually work that way. So we want to think about having a shared decision-making conversation with your patients. We want to think about their risks and kind of do a one-on-one by context. Other things to think about would be, before you wallop them with a vaccine over the age of 26, is making sure that their insurance will pay for it. Otherwise, it can be up to $300 a dose, which is not great if you're not expecting that cost. But really having a one-on-one decision-making conversation and seeing what they feel their risk to be and also what their comfort level is. So finding out more information, the CDC has lovely sites that are accessible to everyone. They also have great videos that'll go through some of the clinical vignettes that I've gone through today in more detail. I think the important thing to end on is that you, as a provider, as well as all of your staff, need to be on the same page. You want to align communication. So you want to talk to your office staff about HPV vaccine, what it does. If there's any myths that you need to dispel, please do them. Because these are the people who are going to be answering questions when the phone rings and are going to be scheduling patients for their follow-up HPV vaccinations. There are talking to parents handouts that are handy to have at the front desk. Just reinforcing that the HPV vaccine is normal, just like any other vaccination that you have in your clinic. Keeping staff up to date, you can do this through the CDC website as well. Continuing education is available. And then as you're reflecting on this, know what your vaccination rates are. How good of a job are you doing personally as a clinician, as well as your office? So take a look at this and then thinking about what quality improvement studies can we utilize to improve our rates. Health departments are very handy to help with this. Professional organizations, the AAP, as well as the CDC, have a lovely step-by-step QI program that you can do. But familiarize yourself. Go through your EHR, go through your immunization information systems, find your vaccination rates, figure out how to find your vaccination rates, and then make this into part of an everyday. The patient comes in, what immunizations are you due for? Catching those opportunities so that we can take a rate of 64% for that first dose and increase it toward that 95% rate. Because HPV vaccine is cancer prevention and you are the key. Thanks everybody for coming today. I hope that this was helpful, and if anyone has any questions in the last few minutes, I am happy to answer as best as I can.
Thanks so much, Amy. Okay, let's see. I hope I'm showing my camera. Maybe I'm showing the wrong one. Let's see. Oh, okay. Okay, so please write your questions on the question drop-down menu. And while you are writing down your questions, I'll go over some things to remember. Remember that we will email you the CME CE instructions, and you'll have in written how to get your certificate and how to watch our recorded videos via our YouTube channel. We'll send you the link as well. Please claim your certificate to complete the program evaluation. It'll take just a moment and it will be of great help to us. Please consider that the activity code expires in 1 week. And feel free to send any questions to my email. You can see it on the page, on the screen right now. The activity code for today, it's here on the page. And if you just use the QR code with your phones, it'll just open up. Again, that's the website, www.eeds.com. And the activity code to enter on that website is the one that you're seeing right now. If you have any trouble, feel free to send me an email and I'll help you. So now let's see if we have any questions. Okay. You need a speedy fingers to type quickly. So, well, I think every point was dotted and every T was crossed. So we don't have questions today, which is great. Again, if, as I always tell you, if there is any question that comes up after the webinar, feel free to send us an email and we'll make sure to answer it for you. And I think that's it for today. Thanks to Dr. Amy Weiser for sharing your time and knowledge with us. We really appreciate you. And thanks you all for participating today. Now you have completed the session and you may disconnect. Have a wonderful, great day, everybody. Goodbye.